Thank you very much, and good afternoon, everyone. It's really been a pleasure. I came early this morning and was able to be here for the whole day, and it's just been a fabulous day. Really, really interesting. And although I was the Chief Innovation Officer for UCLA Health from 2010 to 15, it's been a long time since I was doing research myself, so it's a sheer pleasure to get immersed in some of the questions. So what I'm going to be talking about today is divided in two parts, so let me make sure I've got my clicker organized. And let me just start with the disclosures, a little bit more complicated in my case than in the ones where all it was NIH grants. But I am an executive in residence at AVIA. I'll tell you a little bit about that in a minute. I had been a member of the Aetna board for about 14 years, and when it was acquired by CVS, went off that board. I'm currently on the board of two small companies, Ginger and Consejo Sano. Ginger is a mental health company that came out of MIT, actually, and so interesting backgrounds. And I'm also on the advisory board of lots of small companies, two of them mentioned in the presentation here, so that's why I wanted to flag your attention to those. Because part of what I will do in the second half of the presentation is use examples of companies that are currently on the market with products that consumers are adopting at a rapid rate. And the reason for doing this is not out of any endorsement or certainty that these companies will be the ones that survive and in the end win, but because it's important to understand that this is not just talking about the future, this is talking about something that consumers actually want and adopt, and that plans and employers, if not hospital systems, will pay for. And that's a very important view of what's going on in the world. So I'm going to talk, as I said, about two pieces. The first is focusing on Medicaid and behavioral health, and what we've been learning at AVIA, which is a network of delivery systems, asking us to pool their funds to look at how they should adopt digital technologies. And then secondly is consumer-facing population health. So this is AVIA. It's about 50-plus health systems in the US and represents probably something between 5 and 10% of the market. And as I said, they pool fees, so it's not individual consulting in most cases. It's actually trying to figure out what across different delivery systems will serve them for the transformation of care. It's been going 5 or 6 years, and a year and a half ago, I got started as the executive in residence, a new program focusing on Medicaid, and it now is the biggest single program that we have at AVIA, with over 30 of the members participating. And Andy Slavitt, who some of you may know, and ran CVS, and before that Optum, is another executive sponsor and co-chair of the project. So when we sat down with all these delivery systems and we said, well, what pain point caused you to be willing to come together on this? Why are you really eager? And I mean, they joined in 2 or 3 months. This was a really unprecedented response. They said, these are our problems. This is what we've got to figure out. Emergency room, behavioral health, maternal and child health, and SUD. So half of their concerns land squarely in the bucket of the group here today and of the larger community of efforts that we're involved in. And undergirding all of these, of course, are social determinants of health, which cut across all classes, but as we address Medicaid and underserved populations are particularly egregious. And so we had already been doing work on social determinants of health for about a year before, but we've, since that point, really been in deep dives on each of these topics. And I wanted to tell you a little bit about how we're approaching it, because many consulting groups out there and many people who are technophiles approach this kind of question by saying, well, this is the problem you have. We have an app for that. We have a solution. And that fizzles 90% of the time because it isn't the technology only or specifically that is the solution. It's what the technology allows you to do as a provider or as a plan providing services or access to services for your members. So we start with the major pillars of how people get care in the community: workforce, integration of care, the infrastructure, the payment structure, the regulatory structures. And in that context, we look at what are the challenges and opportunities that our members bring us, the strategic things they care about. They may not be thinking in terms of technology at all. So, for example, broadening access points. They've tried a million different things to broaden access points. Underneath that, when you get into a specific area like behavioral health, there are care models. There are the care models that they're currently using, and then there are the care models that we all wish we could be implementing. I give you the example of community health workers generally in physical medicine as well as behavioral health. We know that community health workers have been proven for 30 years to be very effective, and less than 5% of American patients ever see anything called or even recognizable as a community health worker. So if you go down these care models, they may not be your hit list of the things that you wish could be done in behavioral health, but they stand in pretty good list of care models that many people working in the field in behavioral health wish they could implement and don't have the bandwidth, the financing, the staff capabilities. So what proportion of American patients get universal screening for behavioral health conditions on a frequent basis? We know that should be done, and it's not done. There's no way delivery systems have the financing to hire a bunch of people to screen. So that's the example of a care model. And if you look under the hood of the care models, there are certain capabilities that are core to many care models and cut across them. So you need to be able to target appropriate people for different types of services. You have to be able to screen. These capabilities cut across many of the care models. And in the end, for the health system, and I'd remind you, this is built for health systems, not for plans or employers, there are a series of key performance indicators that they're trying to affect. The key performance indicators are how they would tell whether this is successful or not. So with that framework, you can see there is nothing digital on this list. At this point, what we have done is spent most of our time understanding what it is that the field knows would be good for patients and would be more effective for the delivery system, but for some reason they're not doing or not. We say they're not able to do it. We could always say, well, there's always been 2 or 3 places that have done it, so yes, you're able to do it. But it's not happening as a means of dissemination of optimal models. So then we ask the question, are there some of these capabilities that can be accelerated by digital solutions? Are there some cases where a digital solution can help you get there faster, less expensive, less investment of staff resources, shorter time period, frequently a more complete documentation of what actually went on, because it is digital. It's right there in front of you. Never perfect, but what things might help. From there, we go to what we call our due diligence process. And these are the key criteria we're using on the right-hand side. And on the left-hand side, you can see, whereas we might start in behavioral health with we put out a RFI that's very detailed. It's something like, 40 pages or something. It's amazing that any of the companies fill it out. But we basically often start with around 150 companies responding, we do that. We are a part of the solution. And none of our members, in truth, almost no delivery systems we know of, are capable of doing that kind of sorting through that wealth. It's much more a convenient sample, like who happened to get to you. And then we go through various stages of vetting, and towards the end, we're helping build and understand the business case interactively with our members so that we make sure that this is actually would meet their criteria, would be adoptable by them. And in this case, we came out with 11 solution companies with all of this information available to our members. So I think it is, potentially interesting for the research community to understand what that process looks like, what things are taken into account. Very often the things that aren't taken into account are things that we have no way of measuring. We don't know. So here I'm giving you proprietary information from AVIA, but I think it's really important for you to have the opportunity to see what this might result in. Now remember, this is primarily for delivery systems, and in this country, very few delivery systems have financial risk for their patients. They are still paid for volume. If they have an incentive financially to try to curtail unnecessary care or get more appropriate care, it is in the case of Medicaid and other poorly reimbursed patients. But even under those conditions, you can see that there are notable solutions that we would expect to be on a list if you were bearing risk. Also, as you will see, almost all of these solutions were built for patient populations that have moderate or severe mental illness, because by the time someone gets to a hospital system, they're often in distress. So the more severe in the moderate category or SMI. They have already presented for care, usually in the ED. And the strategic drivers for the system that might pay for the solution are to decompress the ED, prevent hospitalizations when unnecessary or unavoidable, and improve the timeliness of discharge for hospitalized patients so they don't sit on the wards for extra days or weeks. Almost none of these solutions meet the broader need to identify rising risk and mild and moderate mental illness and deal with that. The appetite for that comes mainly from health plans and employers, self-insured employers. That's a very important distinction to keep in mind. So very briefly, I just want to call out a couple of examples that even given those limited circumstances that I think are very high impact. One of them is collective medical, and I'll remind you in every case if I talk about a specific solution from a company, whether I have any financial ties to them at all. But collective medical, which I don't, has real-time visibility into when a patient is observed, admitted, transferred, or discharged from facilities anywhere in the community that are linked together. And a big effort is made in the first couple of months of standing it up to make sure you get all the relevant players linked together. It's initially usually adopted by hospitals, but extends from emergent to urgent care settings, post-acute, mental, behavioral, and all ambulatory settings, as well as ACOs and health plans, because it becomes, in that way, a platform to tell, well, where was that patient a week ago? What did they have done to them a week ago? And it exists mostly on the level of the information of where they went. Sometimes for what happened to them, they have to call. But still, it's in our very primitive, non-communicative health system, it's a big step forward for tracking patients. There are now more than 100 health systems in 18 states that are participating, have adopted collective medical. Openbeds is another solution that, from my point of view, goes even further than that, but it's more narrow. It's a referral tool that in a region or a state reports and offers transparency about the capacity for inpatient and outpatient services and recovery housing and community services for behavioral health and substance abuse. It has an immediate and accurate inventory of the available resources, the wait times, digital registration and authentication, point-of-care digital screening, intake, and decision support, a dashboard to track utilization and referral patterns in real time, and a wealth of reporting tools. This has been adopted as statewide networks in 3 states and is expanding to 5 more during this year. And the reaction from everyone who sees this is, oh, we really want that. The problem is it's usually not enough of an incentive for one hospital. You can't bring it up as just one hospital system. You've got to have all of the different facilities in your region or your state participating. So sometimes it's the state Medicaid or the state mental illness agency gives their blessing to it too. But these are the kinds of solutions that can really significantly impact the way patients are managed in the delivery system. There are also in here 4 solutions that are essentially extending network capacity. So Valera Health does this with remote supervision by psychiatrists of collaborative care model community workers that includes coaching and CBT, and they are now serving more than 1 million patients in 4 states. Concert Health, like Valera, is extending care, but they extend it in the the collaborative care model in the context of primary care. So it's for integration into primary care settings, and they're in 3 states. So again, these are, it's sort of weak evidence that there is market adoption and traction. There isn't much money out there for these kinds of things, so it doesn't go as fast as it would if it was a real expression of how much people feel the need for it. There are also Regroup and Genoa Healthcare, and Regroup is really extending psychiatric capacity using remote availability. They're credentialed at all 50 states, and they're currently serving sites in about 20 states. Genoa Healthcare includes pharmacy and medication management services, and they're in 35 states, but with a somewhat smaller population, about 200,000 patients. But this is an indication of the direction that a lot of this is going. You also see on here Wealth, which I'm going to talk about later, which is a behavioral health app, behavioral economics app for behavioral health, and also 2 companies, MyStrength and SilverCloud, that principally offer cognitive behavioral therapy online. So that gives you an idea of what the world consists of from the provider point of view. But let me change now, and I have to figure out what I look at to get an idea of, I think we're doing okay on time. All right. Now what we're switching to is an area where you don't start with precision medicine. You don't start with the individual and try to parse everything about them. You start with a population and you try to segment and subsegment and subsegment so that you get the type 2 diabetic that is on insulin, that is in poor control, that is Latina, that is over 65, that has family that she's living with, and on and on and on, to understand what tools and interventions you'll use with each segment. It's a very different approach from sort of taking all the omics capabilities and diving into one individual person's clinical case. I call it precision population medicine because it is a science just as much as clinical medicine is. And when I'm explaining to people, I say this is the 80-20 rule. It's the common herd, not the very complex and the zebras that we learned about in medical school. And digital population health doubles down on the 80-20 rule because it says not only can 80% of people be managed most of the time through digital means, but of the 20% that have complex, even the zebras, somewhere like 50 to 80% of the time when they're in maintenance mode, they can be managed digitally as well. And part of the goal, the ambition that you have if you're in population health, and digital population health, is to make your precision better and better so you can serve more and more people. The majority of significant innovations in behavioral health are developed and marketed for health plans and employers because they're really addressing population behavioral health. You know, telemedicine, telepsychiatry, telecounseling, that was new 15 or 20 years ago. It's still an innovation if you measure it by adoption, but it's not an innovation if you think of it as intellectual novelty. So the competition in precision population medicine is to deploy telehealth programs that will essentially include analytics, diagnostics, eventually, and certainly edging there, selection of therapy and behavioral modification at scale. So let me give you some examples. You will find these offering either one or more of these capabilities that AI and precision population health on the front line will provide analytics, identify clinical risk and social determinants of health, assign and test interventions for rising risk in near-term high-cost populations. So we're seeing this now. The health plans for years have used predictive analytic tools to try to understand which members are going to be high cost in the next 12 months. There are currently AI-based, relatively new tools that are, one of the best of them came out of Arnie Milstein's work at Stanford at CERC. And they are already significantly better than any of the commercial tools before out there. And because they know what the guidelines and protocols would assign as the most high-value interventions for the various subcategories of diagnoses that they're indicating in this, they are suggesting that their plan customers in their care management programs orient the care management to those interventions. And this is essentially, if you were running a medical service using guidelines and protocols, you would say, yeah, if we have this segment, we ought to do that. It's simply being able to do it at scale with the analytics. Triage is to assign the site of care. Increasingly, in order to get that, you're essentially doing diagnosis. FDA regs, you're not going to be allowed to say it's a diagnosis. You say it's a probabilistic listing of diagnoses. But the example I'm going to give you came out of Harvard Medical Informatics and is very, very impressive and tested against standard guidelines and protocols for diagnosis and triage. They are 90 to 95% accurate. So they're very strong. Diagnosis and treatment selection, referral. We have lots of examples of e-referral systems out of Mayo, out of Los Angeles Department of Health Services, where 40 to 60% of referrals for specialist care can be prevented by having a two-way templated email exchange, asynchronous, between the primary care physician and the specialist. Often it's a nurse coordinator for the specialist, because a lot of these are pretty plain vanilla when they come in. And this is, you know, it varies by specialty. I mean, essentially, endocrine doesn't really want to see the patients. They just want the numbers. And it'll be of interest to you that one of the most difficult ones for people to mount is mental health, because the primary care clinicians don't even know what they're dealing with or who to refer it to or what to do. And somewhat reasonable, I think, reasonably, the mental health professionals have this feeling like, well, boy, this person hasn't had any kind of workup when they get sent to me, when the information gets sent. So that's an area we want to really dig in on. And chronic care management. So This is the first example, and this is the one that I was talking about that came out of Harvard. It's Buoy Health, B-U-O-Y. And you can go on to Buoy Health. It's just go to Google search, put in Buoy Health, and put in some condition, you know, the symptoms of some condition you have, and see how it comes up. There are almost all the other companies that we even would run into in the US have come out of Europe, where there are national health systems and there's more incentive to try to meet people's needs for this kind of intake and triage. Buoy, in its first 15 months, grew from 0 to 40 million users, of whom 23 million were unique users. And basically all that was search engine optimization, that the consumer comes onto it. They could go to just do a Google search for the symptoms themselves. They can go to the Mayo Clinic site. They could go to WebMD. A certain number of them wound up going to Buoy and liked it enough to stick with it, and a significant number, between 23 million up to 40 million, came back for a second condition because it was a satisfactory experience. By the end of where they hit in 15 months, they were hitting 3 million visits per month. It took 10 years for the best-known Doc Finder application to get to that point, and 7 years for Netflix to get to that point. So the need out there is pretty strong. When I talk about consumer demand, you know, consumer adoption signals the need. Remember Clayton Christensen, you know, one of your home guys, and the father of innovation in healthcare. The way he defined disruptive innovation is innovations that come in laterally. The dominant players don't see it coming. That it is convenient, it's cheap, this doesn't charge the consumer anything, and it's good enough. It doesn't have all the bells and whistles. It's not like sitting down with a primary care physician to ask all these questions, but it is good enough to get used. By the way, I talked with Andrew Lee, who's the CEO, who was a physician trained here, just a couple of weeks ago for a different reason. But I asked him about behavioral health, and he said, well, you know, we were built with the expectation we were just going to do physical health. We wouldn't do behavioral health. But we found it was very, very difficult to draw a clear line between the two. And so we're wrestling with it. Now, if a symptom is potentially behavioral health in nature, then we, like for example, a sleeping disorder, something like that, or difficulty sleeping, we can help them understand what might be going on, but we really have to refer them pretty immediately. But where Buoy is going, what they'd like to do is build longer-term profiles of their users to understand them more deeply, recognize the patterns of physical symptoms that could be indicating underlying behavioral health conditions, and also intake their reported behavioral health symptoms and help them figure out, because ultimately this is triage, help them figure out where they can go for frontline care. And he said, and this was to me the most interesting part, that this is not hard in physical health. I mean, basically, you go to the emergency room, you go to urgent care, you go to primary care, or it's watchful waiting. There's only 4 or 5 things you can do. And in physical health, 31% of the patients that come on online are referred for watchful waiting. Of the patients who come on with the expressed intent to go to an emergency room, 50% of them are referred to lower levels of care. And all the other levels as they come on are referred to between 30 to 50% to lower levels of care. So you can see why Optum was an early investor, Humana is in there, Cigna is in there, all the health plans are in there because they ingested 24,000 articles and guidelines and protocols to come up with their algorithms. And with that kind of scale, they're able to learn very, very rapidly as well. But what Andrew said is in the case of behavioral health, the idea of triage is much more nuanced. Where someone needs to go is much more complex and granular in the community in terms of the types of services that are available. And so they are, and this is a blatant advertisement, I have no financial ties to this at all, they are looking to hire more people with behavioral health, mental health training. And they're right here in Boston. And I think they are a great company. I mean, whether they are the winners in the long run, this consumer need will drive us in this direction. We need services like this. They were, as I mentioned, came out of Harvard. They were incubated in the Harvard Innovation Lab. And their first medical advisor, Warner Slack, was the guy who founded the Center for Informatics at Beth Israel. So it's a homegrown institution. So let me move on to, so that's triage. Let's talk about primary care. So this is entirely text-based primary care. And I am on the advisory board for this company. And in another year, I'm sure there'll be 2 or 3 others doing this, and I can use another one for an example. But right now, they're out there. And basically, when a patient comes on, just like the triage kind of company, AI chatbots bring you in and say, I'm the doctor's assistant, I'm a computer, I'm going to text with you back and forth to get a history, and can ask for photographs to be sent if that's relevant. And then the physician comes on, having read what the chatbot has reported, and has a text conversation with the patient until the physician decides what she thinks the diagnosis appropriately is, and the treatment plan, and that goes back to the chatbot to finish the appointment and arrange for follow-up or whatever else needs to be done. They can send the patient to LabCorp or Quest for labs if necessary. But under those conditions, over 95% of the incoming conditions that are truly primary care are resolved without a need for in-person care. So it's available today in 50 states and DC, so it's accessible to 100% of the US population. Their salaried physicians are licensed in all 50 states, so the telemedicine problem doesn't apply. At the end of their first year, they had 100,000 members. They've just signed a big contract with Walmart. As it notes here, say over 200 different conditions are treated each month, and over a quarter of the visits are returning users, so there's a high satisfaction rate with it. Average patient wait time is less than 30 seconds. Compare to that to the even best primary care setting that you know about. Over 30% of the visits are requested from non-traditional settings, coffee shop, airport, during a commute, from work. Their Net Promoter Score is higher than Apple and Netflix, Kaiser, health plans, and current primary care. It was interesting that as we were doing our research at AVIA, the staff found out about this, and the word started to spread virally, and I got a text later when I asked them about what they had thought about it, and they said, well, most of the staff now are on it, because you can go on and buy a membership for $20 for a year for all the primary care you can eat. And so the cost for employers is $1 per employee per month, 24/7 for all the primary care that the employee wants. So this is the kind of financial restructuring that we will see. Again, whether this particular company is the answer or not, the fact that it's out there and selling well and getting used means that there is need and there is a desire. So let's look at what is happening in behavioral health. There are 4 kinds of things going on. One is a limited number of companies that are offering what are called full-stack behavioral health services for mild and moderate conditions. So here, a health plan or an employer would buy this because, you know, they may have mental health benefits with their regular insurance carrier, but the networks aren't out there, and their employees have to wait too long. And I'm going to tell you a little bit about Ginger in a minute. Then there are the point solutions offering specific tools, mindfulness, CCPT, and digital therapeutics that we heard about a little earlier today, or access to therapist networks, which, as I said, is necessary but not particularly revolutionary. And so here's just a list of a bunch of the solutions in that space. I do want to give a tip of the hat to Pear Therapeutics. I'm not describing them here, but I saw them out in the lobby, and I think this idea of getting an FDA approval of a label is going to be really interesting. My suspicion is it will be very successful, but I think it's a good test of what does it take if providers are not risk-bearing. So if they know CBT is very effective, why aren't they writing for CBT? But maybe what it takes is an FDA label. So we're looking at what are the elements that are required to disseminate something and get it adopted. And then there's condition management and physical health that is migrating into behavioral health. So Livongo was one of the 4 or 5 companies that went public in a big splash in the last 2 or 3 months. And they have done chronic diabetes, et cetera, other condition management. And now they've hired a really great woman from the VA, and they're starting to build their behavioral health solutions in the same way. So, you know, there is going to be more and more companies flooding into this area. Omada, which grew up as a diabetes solution, is now offering mild and moderate behavioral health condition management. Vita was a wellness company that's now going into managing behavioral health. And then there's the telehealth and primary care, like Teladoc, Doctor on Demand, MD Live, even 98.6, all have to decide how do they deal with the fact that you turn up people who have behavioral health needs. So 98.6 isn't doing it yet. Buoy is doing it. Teladoc has been doing it for about a year. But in each case, you have to look, well, what does it mean to be doing it? You know, sometimes it's just making a referral or making a diagnosis and suggesting a generic referral. So those are, that's a general outline. Here is an example of Ginger, and Ginger is one of the companies that I am on the advisory board for. And again, they are the only one that offers essentially same-time access. Because even in this space, all of the other competitors say within 3 days, we'll make sure that your employee or your member can talk to someone. We guarantee half an hour, and there's a ticker running on the website, and if you look at that, it's usually under 60 seconds to be connected. And the first connection is to not an AI chatbot, but a live person texting with you. So you're introduced to your coach, and the 2 other coaches that together serve as your coaching team. So you can always talk with one of those coaches. And as you know, there's a certain proportion, I wouldn't know the number, but a certain proportion of behavioral health patients that actually are more comfortable with a less, they don't want video, they don't want to be face-to-face. So I presume that this is somewhat helpful in that setting. But they basically are managed by the coach to the point where either they need to go into the live streaming telepsychiatry or telecounseling. The coach can assign them to CBT, which they have, and the new app was just launched, which incorporated the CBT that had been developed by Lantern, which failed because it's hard to just be a point solution company. You know, it's just tough to make traction in that. And so Ginger now has all the domestic employees for PwC, and they just signed all the domestic employees for Delta. So they're beginning to accrue really large patient populations. So what I want to say here is that there is a huge need for partnerships with researchers, that, you know, we're getting our hands on all this data. And anyway, I'll come back to that later, but I think this is a very important thing. So here we did sponsor research by an independent third party just to find out what employees thought about all this. And one of the questions we asked about workplace stress is, have you ever cried at work? Almost half of American workers represented in this survey have cried at the workplace. I don't know if they're all female. I don't know, but it's pretty shocking. Attitudes are changing towards getting support. People are a lot more willing to seek support, but there's still big, bad stigma for older males that keeps them from doing it. And it's very important to them. It's important to them in choosing a job, and they rank them over financial advising, gyms, free meals, all the other benefits that it's often lumped with. I want to touch on two other technologies quickly before I end. Behavioral economics should be a part of the armamentarium when you were hearing this morning about comprehensive tools for elderly patients, for behavioral health patients to manage their ongoing conditions. This is a smartphone, and the company puts $2 a day as a lump sum, $180 for 90 days, into a bank account, and you lose $2. It's loss avoidance. You lose $2 every day that the patient doesn't take a picture of their meds in their palm of their hand. They've done this with duals, so Medicaid, Medicare, elderly, multiple comorbidities, diabetics, COPD, post-MI, CHF. In the duals with diabetes, they went from 31% medication adherence to 85% medication adherence. Habituation in behavioral economics usually happens around 66 days. By the end of 90 days, they assumed that they would shut the program down for each individual patient after the 90-day period, but the health plans don't want them to. They're willing to keep paying for it because the decrease in hospital admissions and ED visits is so huge, they can afford to keep them in the program. And when I think of the number of care managers we have on the phone, visiting the home, everything else, this could be a part of the answer. I find it very exciting. And they have 4 or 5 cases of behavioral health, including population recently discharged from long-term psychiatric treatment, where they find equivalent kinds of improvements in medication adherence and completion of behavioral health appointments, follow-up appointments, and physical medicine follow-up appointments. So it seems to be reasonably effective. All this stuff is early, so that's why I'm shrugging and sort of, making gestures, because I don't want to sound like I just, drank a lot of Kool-Aid or whatever, but it's exciting to see the directionality, even if these aren't the right solutions, even if we learn next year that there's something better than sliced bread. We're getting closer to something that really is a big change. And the last one is Consejo Sano. Not only do we know the country is getting more diverse, in California, our Latino population is 30 to 40% of the state, 5% of our clinicians speak Spanish. We know that culture and language is a huge barrier. Most health plans can't communicate with 50 to 20% of their members for those reasons. And so this was built, and this one I was originally on the advisory board, now I'm a board member. This offers culturally and linguistic appropriate versions of what the plans want to be saying to their members. And in a study at UCLA, which I wasn't a part of, they went to people who they essentially weren't able to get in touch with, to 85% adherence to the appointments and programs that they wanted them in, addressed almost 2/3 of the gaps in care, meaning people who hadn't come in for a follow-up visit of some kind, and with a very significant return on investment. And they do it by what we call cultural detailing. So you understand, as I was saying before, this is a second-generation Korean-American, parents don't speak English, live with this person, is the sandwich generation support for 3 kids and the 2 parents, on and on. You begin to build out an understanding. It mixes with social determinants, too, to a large extent. So those are some of the areas in which I think what we're learning from the consumer, the patient, is that in order to compete and be successful in the future, it's not so important just to be good at what we're doing according to the traditional definition of what it means to be good at it. It's doing what the customer values. We never, on our own, probably would have thought of text-based mobile primary care as acceptable and covering that much bandwidth, but it's because we finally have consumers who really want it. And we've made it so complicated and expensive that there isn't much alternative. So thank you very much. I'm sure I'm at time, but thank you very much for the invitation.
Hello? Okay, you can hear me. Would you mind joining me here? We can have a seat. Hi, I'm Mona Potter. I'm a child psychiatrist, medical director at McLean. I'm the Child Outpatient Services, and we will address some of the questions. Thank you to those of you who sent in your questions. We are running a bit short of time, so we'll probably have time for about 2 questions, if that's okay. No, it was a really great presentation. Thank you so much. I really appreciate how you were kind of thinking about the big picture and how kind of helping us think about a different way to approach how we're helping our patients. So we have a lot of clinicians in the room, and so one of the questions that came up is, how do you think partnerships between young companies and academia are best created?
Okay, yeah. I've been partnered with or working with young companies that have tried to do this a number of times. And could I just see a show of hands? How many people here have tried to work with a young company or had discussions with them about whether research could, yeah. I think that the need is not just to have individual good academic researchers go out and try and find a company, or for a company to try and come and find a researcher. I think there's some fundamental problems here, and we need a small working group, and if you could do it in Boston, it would be great. Because there are structural reasons why this doesn't usually work out very well, and in some situations it's great. But basically, the small companies don't traditionally have the money for the kind of studies that we usually require. So maybe on our part, we can start thinking about some of the PCORI work and the patient-reported outcomes work, and we can think about the methodologic controversies that have gone on, and sort of, we were beginning at UCLA and didn't get very far with this at that point, to look at what the potential would be. I do think that we've got to, especially with these large databases, we've got to use them collaboratively to learn. And I don't think that I have a lot of good answers, except that the patients deserve it. And I think that even if you got just 1/3 of the young companies to be willing to engage, it would be more than you could possibly handle.
Thank you. So let's see. So another question that was very popular. So given the enormous wild west of apps and tools, is there a clear systems level approach to validation and prioritization?
Yeah, there are actually several organizations that play that role. The New York State Hospital Association had a big effort that did that. I'm not sure if it's still continuing. As health provider systems aggregate, they tend to do it themselves. And there's a particular solution, Zinx, if it's still called that, XYNX. It came out of Microsoft folks who were working with the Providence Health System, and they built a tool that gets integrated into the EHR, Epic and Cerner, and then probably a couple of others too, so that the physician has a curated list of apps in front of her and can actually prescribe an app to the patient. Because I'm not sure that there's really going to be anybody who can take on vetting every app out there. So what they go through is a process with provider advisors and experts to narrow down what's needed and what the criteria for selection and vetting would be. So I'm I'll look it up and I'll get it to your conference organizers, what the name of it is, just so you could look at it, because I think it's very valuable to physicians to know what they could prescribe.
All right, thank you. That's really great. And so then the final question before we go for a coffee break, a question that many people were asking specifically about Ginger. They were wondering how you get enough coaches to provide service within the 30 minutes and kind of how to kind of manage that decentralized.
Yeah.
Yeah.
Well, you know, it's funny because you always think in a software as a service kind of solution, how protectable is it from an IP point of view, but actually probably our biggest protection is the knowledge we have about how to qualify the coaches and how to train, you know, give them the specific training for the text-based coaching. And so we take as much as possible credentialed coaches who have always people with a lot of experience in coaching, and we have a very thorough training program for it. There doesn't appear, it's a little bit like a lot of the nurse online services. There are a lot of people out there who prefer that way of working. It's quite interesting. And so we have, I wouldn't say we don't have trouble, but it hasn't been a major barrier. It's more a question of that the response has been so strong that it's just scrambling to keep up with it. It's a little different when we try to find psychiatrists. That's hen's teeth, so.
Slower to the uptake.
Just not enough of you, so.
Yeah.
Anyway, but thank you very much.
Yeah, well, thank you again for just kind of helping us think about a different approach to how we've been operating, right? I mean, I think it's important for us to really think more broadly about how we approach these problems, so really appreciate your presentation.